enjoy learning about other people's achievements. How did they do it? How can you do it? So for the next 30 minutes, sit back and relax while you and I explore these very special wonders that make people successful and interesting. Welcome to my world, and Dr. Passes presents.
I've got a fascinating show for you. This show will be so interesting because it's going to be a show about things you would like to talk about, but you might be a little squeamish about doing it. So you'll understand when you see my guest and the topic on the show, but I think you're going to get an awful lot out of it. So without further ado, I want to bring to you a fascinating, terrific individual, Dr. Nathan Schulman. Terrific. And let me just tell my viewer at home a little bit about you. And Dr. Schulman is a gastroenterologist, and you went to the University of Kentucky Medical School. You then went ahead and did an internship and a residency at Long Island Jewish Medical Center right down the road here. And you then continued, because you liked it so much, you had a fellowship in gastroenterology at Long Island Jewish, which we're going to discuss today. You were also, again, you loved it so much, you were their chief medical resident at LIJ, and now you practice medicine and gastroenterology. Actually, you've been doing this since '86 until now, and you're involved in a very interesting group. You're associated with a team of gastroenterologists, specialists, and the team is called Digestive Disease Care, which is kind of self-explanatory. And you got working with you 17 doctors in this group of specialists. And the groups, you have multiple offices in Queens and Long Island. And I want to tell my viewer one other thing. You are one hell of a doctor, and you're a great guy. And people who know you love you because you know how to reach people, which is just terrific. So I want to thank you for coming down. And that's the end of the show. No. Let's talk now a bit all about, so let's start. What is a gastroenterologist?
It's a doctor who specializes in diseases and in maintenance of the digestive system, which includes from the beginning of swallowing, going down the esophagus, the stomach, the small intestine, the colon. It includes the liver and diseases of the liver, and that's basically a subspecialty.
So you come after me, because I take care of the teeth.
Correct. We're right after that.
So after me, then you step in.
That's correct.
Okay. So you don't do any teeth work?
No.
Okay. Why is this a specialty? What's the,
because
why does medicine need it?
It's such a large organ system, and there are so many things that can occur with both the upper and the lower part, that whereas general internists can get involved and make some diagnoses, only we can deal with certain aspects of it, including looking inside the stomach and looking inside the colon and dealing with certain liver disorders.
You know, it's interesting what you said. It's a large organ system. If you're a cardiologist, the organ you work with mostly is called the heart, or if I can go on and on, it's that. But you're right, I never looked at it that way. It's multiple organs.
Correct.
And so you've got to be really knowledgeable, and especially in internal medicine, I would imagine.
Yes.
So it makes a lot of sense. Okay, before we get even more into this, and we're going to discuss two major testing procedures that you use. One is called a colonoscopy. So tell my viewer, what is a colonoscopy and why should it be done?
Okay. So a colonoscopy is where one cleans out their colon so that we can insert a tube that has a video chip at the end of it. It also has these channels that we can insert instruments through in case we have to either remove or take pieces of tissue from the bowel wall. And it becomes very, very important, A, as a screening tool for colon cancer, which has become one of the major killers in this country, unfortunately, and to look for causes of bleeding, which can occur where people can have blood in the stool or see bleeding coming out when they're going to the bathroom. Or if they're having diarrhea and we can't find any other etiology for it, there can be inflammatory conditions of the colon or other parts of the GI tract that can cause that.
I see. Okay, so that's going from the bottom up.
Correct.
Now, do we ever go from the top down?
Yes, absolutely.
And that's called?
An endoscopy.
Endoscopy. Could you explain to my viewer what is an endoscopy?
So basically, again, it's a tube with a video chip and channels that we can put instruments through that goes down through the mouth in front of where the vocal cords are and into the esophagus, which is the beginning of the feeding tube, all the way down the esophagus into the stomach and into the beginning of the small intestine.
I see. Okay. I know my viewer is thinking, are you guys nuts? I'm not doing that. That's going to hurt. That's going to be painful. And they're sticking something down my throat. How do we get around people feeling anything or choking or et cetera?
So both procedures are done under what we call IV sedation, which is not general anesthesia, but they're given medication through an intravenous, or what we call propofol, which gives them a very, very nice, wonderful sleep. Most people say it's the best sleep they've ever had.
But Jackson said that. Yeah.
So yes, but they don't really feel anything. They don't feel the tube going down the throat. They don't know. As a matter of fact, most patients, when the procedure's over, saying, "Did you really do the procedure?"
Correct. Right. And so that my viewer understands, this is very similar to going to the oral surgeon and having a wisdom tooth pulled. They give you sedation, you're out, you wake up, the tooth's gone, they never knew anything.
Correct.
Same thing.
Correct.
Which
Exactly.
is great. And listen, I've had you take care of me now for years, and it's easy. It's easy peasy. It's really simple. It's terrific, which is great. Okay, so the colonoscopy and the endoscopy are very important tests.
Absolutely.
Okay, are they considered the gold standard of testing?
So for colon cancer prevention right now, definitely colonoscopy is the gold standard. Aside from giving the best potential aspect of finding something, you can also take care of it at the same time, whereas all the other testing measures out there right now do not. It is also the most accurate of all of them. The other testing procedures for colorectal cancer is the Cologuard, which is the little box that everybody sees advertised on TV.
Yeah.
That has a lot of false positives and negatives, unfortunately. And if it's positive, then it's an automatic colonoscopy. You have no choice because
you got to do it
why
anyway.
is it possible?
Right.
So and now they're starting to have some blood tests. Again, it's too early to tell exactly how accurate they'll be, but they may be the future.
Okay, so let's talk about colon cancer. I'll ask you a real stupid question, because we all know the answer. Can you die from it?
Yes, absolutely, unfortunately.
Okay, so my viewer at home's saying to him or herself, wait a minute, I can die from this thing? What do I look for? So what do you look for? You're home right now, you're watching this.
So there are several quote-unquote warning signs that we get concerned about. The primary number one is blood in the stool or bleeding. That always should be looked into and never ignored.
Big flag, red flag.
Big red flag, absolutely. The other is a marked change in bowel habits. Now, sometimes it may mean nothing, but if all of a sudden you've been going to the bathroom all your life one way and then something changes, it's something to say, well, what's going on? Changes in the size and shape of the bowels, if they become narrower and if they become darker in color, all of those are things that should warn you that you should see a gastroenterologist.
Okay, later on in the show, I want to talk about that. And not at this moment, because there's so many other things that I want to ask you. At what age should someone begin testing? I know this is changing.
Yes. So right now, the current recommendation is at age 45 is the start of screening. If there's a significant family history, we talk about 10 years prior to when the person who had the colon cancer presented with it is when one would start. And there are certain genetic diseases where age isn't important or a factor involved at all.
It's the genetic, which is the factor.
Correct. And if they have certain, and again, there's genetic testing, blood tests to test for these things. There's an entity known as the Lynch syndrome, where these people have a very high incidence of having colon cancer. They get colonoscopies almost every 1 to 2 years. And they start very young. We don't wait till they're 45 to screen.
Okay. All right, that makes great sense, and it's so easy to do. I mean, you don't even patient doesn't even know anything is being done. All right, what is it that you might see if you have Mr. Smith's in the operating room, and you go ahead and you do a colonoscopy, and then you look? Do you actually see things? What do you see? Tell my viewer.
So we're looking at the entire lining of the colon itself. Mm-hmm. So if there's any growth on the lining, which are polyps, and there's multiple different types of polyps, adenomatous polyps, and again, there's subclasses of adenomatous polyps.
Right.
But those are the polyps that can become cancers if they're left in. Nobody knows the exact timing of how long, but they're the things that if we see any polyp, we remove it right then and there.
Right then.
We take it out, we put it in a jar to be analyzed by the pathologist.
And you have lunch? No. Have it analyzed.
And we make sure what it is, make sure that there's no gross atypia to the cells, because that would create, if it had what we call high-grade dysplasia, which means that it's already really starting to turn into a cancer. Those patients, we become much more aggressive and even talk about doing colon resection on. The earlier one finds a cancer in the colon, the better the prognosis is nowadays. And I mean, if it's found really early and doesn't go through the wall to any of the lymph nodes or the organs, the prognosis is excellent. If it goes to the lymph nodes, again, it's still a much better prognosis, but the further out it is, and if it's in other organs, then the prognosis becomes much, much worse.
I see. I was going to ask you a question which you kind of answered. So many people are just so frightened.
Yeah.
And they ignore it. Oh, it'll go away. No, what'll go away is you.
Right. It doesn't go away, unfortunately.
It doesn't go away.
And ignoring it is, and I understand, a lot of people come in, I don't want that done, I don't want that done, or they'll say, I'd rather have a Cologuard. And then the Cologuard comes out positive, and then they have the colonoscopy, and thank God, you don't find anything other than a polyp or whatever. And they say, it really wasn't so bad. I can't believe I was so nervous about it.
That's the whole thing. Yeah. And that's the purpose of having a show like this, to have that conversation so that the viewer at home can say, maybe it isn't as bad as I thought it is. I don't want anybody doing that to me. You don't know what's being done. You wake up, you're finished, and it's the end of it. Okay, is there more that we can talk about as far as colon cancer testing and treatment is concerned? Before I move on.
I mean, treatment-wise, as I say, thank God they've made great strides in the between the therapies they now have available, and immunotherapy and the surgical procedures done to remove lesions. It's made dramatic leaps and bounds, thank God. But the early detection is the key. That's really
early detection. That's in everything.
That's the key.
That's in everything. Okay, let's discuss another common problem. Heartburn.
Yes.
Heartburn. Now we're going on the top.
Yes.
Okay, heartburn. What are the causes of heartburn?
So basically, it's when acid, and sometimes bile, but mostly acid, comes up through the little sphincter at the bottom of the esophagus, of the feeding tube, and goes and irritates the esophagus. That's the burning sensation. There are some people that have what we call reflux, and reflux is that acid and or bile coming back up the feeding tube.
From the stomach.
From the stomach. It's not supposed to come back up. There's a little sphincter muscle that's supposed to be very tight at the bottom of the esophagus that only opens up after swallowing, because neurological impulses are sent, and then it sends a little signal to the bottom of the esophagus. Okay, food's coming down, saliva's coming down, open up to let it in. It goes in, and then it's supposed to close again. Now, either because of the laxity of that sphincter, where it just loses its tone, or, which is a very another common entity found in about 50% of the population, what we call a hiatal hernia, people will get what we call gastroesophageal reflux disease, acid and or bile continually coming up. If it comes up and irritates the back of the throat, it's the same entity really, but they call it laryngopharyngeal reflux, only because now it's really irritating the vocal cords, and it can cause hoarseness, it can cause throat clearing, it can cause a feeling of mucus continually in the back of your throat, and yet patient may not even feel any heartburn.
I had that for years, and this was GERD, gastroesophageal reflux disorder, wasn't even diagnosed yet, and no one even knew what it was. Right. And here I am with feeling talking like this. It
can be very, very, very aggravating in that respect.
So I had asked you what causes it, and you said, well, you could have a weakness in the sphincter, in the valve, that trying to keep everything down. It lets it up and comes up like that.
Correct.
Are there other causes?
So again, the hiatal hernia, which is basically the space between your two diaphragms, is called the hiatus. And when that's enlarged, which is usually from birth, unless somebody's had some cardiothoracic surgery, because it's enlarged, the stomach, which normally sits underneath the diaphragm, now can slide up and down through that opening.
Oh, God.
So when it slides up, the chest, by the mechanics of breathing, has a negative pressure. It pushes against the stomach, allows the acid to come back up and cause the irritation.
Wow. Okay. How do you treat this?
So first we always do is dietarily. There's a lot of foods and things we like red sauces and fried foods and tomatoes, chocolate, onions, alcohol, onions, garlic.
Stop it! You're getting me hungry.
But all of those wonderful things that can aggravate reflux. And then there's a host of medications. There's the simplest medications, which what we call the H2 blockers, which is now the only one out there really is Pepcid. There used to be Pepcid and Zantac.
Right.
Zantac now is really the same active ingredient as Pepcid. And then there are what we call the proton pump inhibitors, which are stronger medications, which actually inhibit these little pumps that produce hydrogen ions, which is the acidity within the cells of the stomach called parietal cells. Mm-hmm. Those medications, even though they all advertise as 24-hour once a day, they work, but they don't really inhibit those pumps for 24 hours because those little pumps are continually regenerating themselves. But they work for a good amount of time, and even though their half-life is really probably somewhere between, depending upon which drug, 12 hours to 18 hours to 19 hours or so, it is definitely suppressing the acid, but it's not totally stopping the acid.
Mm-hmm. Okay, so you got diet, you got medication. What about surgery? If someone's really going nuts.
So there are surgical remedies. There's most of them are done laparoscopically. They're
meaning you don't have to be cut open.
Correct. What they do is they go in with 3 little openings from your stomach. They do, it's called a Nissen fundal plication. Fancy name. But basically what they do is they wrap the stomach around the esophagus to make an artificial sphincter, and then they kind of tack the stomach down to the diaphragm so it can't slide up and down.
And that's a non-reversible procedure.
Correct. Although most of the time those wraps become a little loose, and patients end up getting recurrent symptoms of the acid after a while in a lot of cases.
And they got to have it done again?
Well, most of the time at that point it's just managing with medication. We don't usually recommend going back in.
What a mess.
Yeah, it can be a mess.
That is a mess. Okay, so that's absolutely fascinating what you're talking about. And this is a day in your life, Okay, can acid reflux lead to more serious conditions?
Yes, it
like
can.
What?
So from chronic irritation, it can lead to strictures and narrowing of the esophagus, where you may not be able to have food go past. It can lead to an entity called Barrett's esophagus.
Syndrome or Barrett's esophagus.
And Barrett's esophagus is basically the cells that are lining the esophagus are what we call squamous cells. The cells that line the stomach and the small bowel are called columnar cells. To protect itself, the esophagus adapts and undergoes what they call a metaplasia, a transformation, to become more like the cells of the stomach and the intestine, so that it protects the esophagus. The problem is once you start a transformation, those cells can continue to transform and then, God forbid, go on to become esophageal cancer in the worst case scenarios. We monitor people with Barrett's by doing endoscopies every few years to make sure that those cells don't change at all.
And how serious is conditions of the esophagus, and how easy is it to treat?
So conditions of the esophagus can make people miserable, unfortunately, because if you feel the food getting stuck, or feel it can't go down, or it hurts when it goes down, it can be terrible pain. Having heartburn where it's burning continuously when you're lying down at night can be terrible, and if it comes all the way up, it can even make you feel like you can't breathe, because it can irritate your vocal cords and cause issues in that respect. They can be treated readily with the medications, again, if you don't wait too long. If there's been chronic damage and you get narrowing of the esophagus, then you have to go through what we call dilatations, where they put balloons in to blow up and then rip the muscle so it can open up again and heal. So that becomes unpleasant, in that respect.
Oh, God.
We like to prevent that.
And if you have esophageal cancer?
That is not one of the better cancers to have, unfortunately.
Right.
It's again, eating becomes extremely difficult, and treatment of esophageal cancer is not one of the better modalities, although, as I said, they're getting better, thank goodness.
Wow. Does smoking affect this?
Yes, smoking affects acid secretion, number one, and there is a much higher incidence of esophageal cancer, as there is lung cancer, in smokers than in non-smokers.
What about drinking alcohol?
Also, alcohol in itself is irritating to the esophagus. It's also what we call a vasodilator, which dilates up the blood vessels. So blood flow to the stomach and the esophagus can change in that respect also, and it can lead to more irritation and inflammation of the esophagus just in its own right.
It's amazing all the things we do to ourselves.
Yes.
All right. Let's go to another guy who's very important in the body, the liver.
Sure.
Why is the liver so special?
Because everything that you ingest gets detoxified by the liver and the liver cells. Everything we put in. Every drug gets metabolized. There's a whole enzyme system in there that can compete and change the way medications go into your body, but it detoxifies everything that you take in.
Okay. And then it just helps you to excrete it somehow, to get rid of it.
Correct. Goes back into the blood flow.
Okay. You hear more and more today about fatty liver. And in the past, you talk about fatty liver, oh, he's a drinker. He's a drinker. I want you to address all this, because today people get fatty liver who say, but I don't drink.
Right.
So can you explain to my viewer? What are you
at one
about?
time, the most common cause of cirrhosis of the liver, which is where the liver is destroyed.
Cirrhosis or cirrhosis? Go ahead. I couldn't resist that.
That was very good.
Go ahead.
The most common cause was, at one time, hepatitis C, then alcoholism. Now the most common cause is what we call MASH, which stands for metabolic dysfunctional associated steatohepatitis. What does that mean? So fatty liver is basically where there are fat cells that become interspersed within the liver cells themselves. In its own right, just having the fat cells in there doesn't necessarily cause damage to the liver, but there are many people who develop an inflammatory process associated with that, and that causes inflammation and then fibrosis. Fibrosis is when the cells become damaged, and as they continue to become damaged, that fibrosis will eventually become cirrhosis if it's not addressed and treated. So the most common causes of fatty liver are obesity, which in this population and day and age is unbelievable, very common. Diabetes is another very common cause, and there are many people with diabetes, and they also get a higher incidence of fatty liver.
Wow. Okay. Can it be treated?
Yes, it can nowadays, thank goodness.
Medicine?
So the first and foremost therapy is weight loss. Okay, obviously the best way one would want to address weight loss is by people being able to lose it themselves, and diet and exercise. Unfortunately, again, that becomes much more difficult in this day and age for the majority of people. That's where the wonderful GLP-1s have become extremely useful, and they've become indicated in MASH because by helping to lose the weight and by some anti-inflammatory process in the liver, they decrease the inflammatory process, and if there is fibrosis, can start to reverse the fibrosis. If there's greater than, and fibrosis is in stages, there's F0, F1, F2. F2, F3 is already considered to be significant fibrosis. F4 is where you're already in the cirrhotic stage. Okay, so if between an F2 and an F3, aside from weight loss, there's a medication out there called Resdifra, which works on and again, it's called metabolic dysfunction, on that dysfunction within the cells themselves, and decreases the inflammatory process and reverses it.
Let's change the subject. We got about a minute or two, so just very quickly, explain gastroparesis.
So gastroparesis is when the stomach doesn't empty. The wonderful GLP-1s we use, they cause gastroparesis. That's how they help in weight loss. But it's basically when the nerves to the stomach are affected, and the stomach, rather than emptying, which usually takes somewhere between 2.5 hours, is prolonged and food sits there. That can make you have more reflux, make you very uncomfortable, make you feel full, make you lose weight in that respect.
I see. Okay. Very, very interesting. There's so many other things I want to ask you. Very quickly, we discuss H. pylori, you and I, and you test for it all the time. What's the big deal? What is it?
So H. pylori is a bacteria that is transmitted via food. We don't understand why certain people get it and others don't, but there is a higher incidence of it causing ulcers in its own right, and a much higher incidence of developing certain lymphomas of the stomach and cancers of the stomach if you have H. pylori and don't eradicate it. And
you can be treated for H. pylori?
It's treated with a combination of antibiotics and those medications for acid.
Okay. Is there any difference? Is there a reason for someone, this is the disgusting part, is there any reason why people should examine and look at their stool?
So yes, because you want to make sure you're not seeing blood in the stool. And as I say, if there's something that's grossly changed, where all the time you're having a nice formed stool and then suddenly you're having narrowed stools that are constantly coming out narrowed, or you're not going the way you were, or you're going much more frequently, it becomes important to look and see what's going on. Everybody thinks it's disgusting, but it's important.
And if you see it, say something.
Correct. If you see something, say something. Go to your doctor. Go to your doctor.
And you don't have to be embarrassed.
Correct.
Correct. Terrific. Okay. Also quick, does it matter how many times a day one poops?
So the answer is no, because it varies from person to person, and it varies on the motility or motion of their gut. And what's normal is what's normal for each individual. That's why I say if it's different from your norm, if all your life you've been going after every meal, that's your norm. If somebody else says, well, I only go once a week, that's their norm. But we prefer people to go every couple of days.
So don't you think because he does it, you should do it too?
That's correct, 100%.
Okay, we got about a minute left. Can you just give my viewer any tips?
So, I think the most important things are, as I say, if you see something different, if you're feeling something different with your body, don't ignore it. Go to your doctor. Let your doctor tell you if he thinks you need to see a gastroenterologist, and he'll refer you. Make sure you keep up with screening, just like women go for mammographies and for their gynecological exams, their colonoscopies should be done. And in terms of one's colon health, definitely having enough fiber and fluids in your diet on a regular basis are critical. And I'm a firm believer in probiotics and the bacteria of the gut. I think that that's very important, especially with all the junk food and garbage that we eat on a regular basis. It's important to keep up with that. And you can get it naturally with kefir and with sauerkraut, things like that, or you can take supplements. But I think that that's important.
Yeah. Okay, that's great. You're a wealth of information. Will you come back again for us to have more shows and to discuss things? I really appreciate talking with you.
Thank you.
You're terrific. Dr. Schulman. As
Thank you, Dr.
always,
Davis.
a pleasure. I just love spending time with you. And I love spending time with you. I hope that you gained something from this. I hope you had a chance to hear things that you're not going to hear from anyone else. You're going to go out for dinner with your friends and they're going to talk about their poop? No. We're going to do it all here for you. So this way you can learn things, you can understand, and you can help yourself. My camera people are laughing right now. I'm not, because I know that this is important. And we will have Dr. Schulman back again, and we will have other people also so that you can learn some more. And remember, prevention is very, very, very important. Best thing I could say now is, see you again next time. Thanks for your time this time. Take care. Dr. Pass is saying, take care.